అది సైన్స్ ఇవి మీరు
Hi, winners. Hope you're doing great and hope I'm audible and visible to you. I just need your quick response in the chat box so that we'll be starting the proceedings. Okay, so in this next couple of minutes, we'll try to cover few important aspects of endo. Uh, they are like must-do areas of endo. Okay, so for sure you will be having questions on these areas and these concepts in your final exam. Yeah, I need your quick response on the chat box so that we'll be starting the proceedings. Yeah, we'll start by 6:05. I need your quick response in the chat box so that we'll be starting the proceedings. Yeah, good evening, Navya. So most of the questions of endo in the recent INICET or in the last NEET examination uh, are inclined to case-based questions. Okay, so even in 2024-25, you have lots of case-based questions which can be answered in the most simplest way if you know few important concepts, and that particular concepts I'll be discussing in the next 30 to 40 minutes. Okay, so we'll try to finish it as quick as possible, but make sure I want every one of you to learn this and yeah, apply this in the examination hall so that 5 marks, 5 safe easy marks will be in your pocket. And make sure do subscribe the channel and keep your bell notification on so that you're going to get all updates related to the live sessions, discussions, recalls, and everything related to MDS Conquer. Uh, I mean, like if you check out the recent questions of Endo, apart from the questions which are on the memory based, you have a concept of case based. Case based is not about the diagnosis, it is about the treatment plan. The treatment plans can be when you are going to go for a deep caries management, or when you are going to go for a pulp capping, whether it's a direct pulp capping or indirect pulp capping, or when you are planning to go for pulpotomies or pulpectomies in the case of your pediatric endodontics, when you are going to go for apexifications, apexogenesis, or when you are going to go for the latest treatment protocols, that is your revascularization and basic normal root canal therapy. Okay, right? So these are the areas every year in every paper you have around like 3 to 4 questions. Even if you take the latest NEET 2025 paper, you have around 4 questions on this particular concepts. Why 4 questions means, yes, it may be pediatrically pedo, from the pedo point of view, they can ask you endo related or trauma related questions that comes under your pediatric endodontics, or that comes under your trauma of the particular teeth, which is part of both pedo as well as endo. And similarly in endo also they can give questions on these particular areas, and that is a main thing that we are going to discuss in the next couple of minutes. I just need a thumbs up sign from all of you so that we will start the proceedings without wasting any time. I need a thumbs up sign from all of you. So we'll try to finish this part quickly, and let's make it as more interactive. Shall we start? Yeah, 6:05. So we'll start. Yeah, yeah. First and foremost thing, yeah, first and foremost thing. So being an endodontist is privilege, and teaching endo to you is definitely a great privilege and a honor to me. So this is my first MDS photograph, which was like 11 years back. So that is my in the initial days, initial first week of my college. So and I really thank from bottom of my heart to my HOD Dr. Giriza Sajan, um, and to my guide Dr. Rambabu sir, who is right now HOD of one of the college, and followed by my seniors and juniors who has helped me so much during my PG life. Uh, I mean, I need to be grateful to all of these people. Because of them, what I am today, what MDS CONQUER is today, because I have started MDS CONQUER during my first year of MDS itself. So it's a great privilege that many people has helped me during that initial phases to turn our mold MDS CONQUER to this level. And yeah, we are done with, we are ongoing with 11th batch, and we are about to start our 12th batch in the next couple of days. So it's like 11 years journey was done, and I thank my HOD and guide and my seniors and juniors. Okay, right. So keeping that aside, so we will jump into the first and foremost important concept. So whenever I have an uh, endodontically treated teeth, posterior wise, I'm a little bit okay, because posterior wise occlusal loads will be more. And in majority of the posterior root canal therapies, even if the crown loss or even if the tooth loss is very, very minimal, I prefer to go with full crown. I regularly go with a full crown in a clinical scenario. There are many clinicians who are attending this class live, and I hope you guys are, it's very common like in the clinical scenario or in the college, whenever you have a posterior teeth RCT, we are mandatory will go for the crown. Reason is because of the load. But whenever this happens to the anterior teeth, okay, can anyone tell me what is the major cause of loss of strength to the tooth structure? Major cause of loss of strength to the tooth structure during root canal therapy. You know that the tooth structure is lost, or the strength of the tooth is lost. So what is the major reason? A very frequently asked question. Okay, so main reason or the primary reason for the loss of tooth structure during the root canal therapy is crown or coronal loss. This coronal loss can be due to caries by Streptococcus mutant or can be due to axis opening. Even I prepare axis opening. So that is a major loss. That is a major loss or the primary loss of the tooth structure. And a very frequently asked question that most of you can answer this is, how much amount of water loss is seen in dentin? How much amount of water loss means during RC? So during RC, what I'm going to do? So during RC, there is some amount of water loss in the dentin. So amount of water loss in dentin during root canal therapy, the amount of water loss in dentin during root canal therapy, the answer is 9%. Is a very frequently asked question. So what is going to happen because of water loss? The dentin will become brittle. Whenever something that is brittle, it is easy to break. Fractures are very common. Fractures, vertical root fractures are very, very common in the case of your root canal treated teeth. Now I'm talking about anterior teeth. So whenever I'm planning to go for a post-end endo, for an anterior teeth, so the most important thing is amount of tooth structure that is left over. Okay, so what is that amount of? It is the amount of remaining coronal structure, because that is the primary reason why I am going for this crown. So what is going to happen? Basing upon the amount, whenever it is very minimal. Why it could be minimal in the anterior teeth? Because anterior teeth occlusal loads are very, very less. So main concern of anterior teeth is about aesthetics. So whenever your crown loss is very, very minimal in the case of your anterior teeth, very minimal crown loss is there in the anterior teeth. Okay. So what I'm going to do, for example, without any trauma, there is a discoloration for which I'm going for RC. So there is no crown loss by dental caries or trauma. So what I'm going to do, I'm going to prepare a conservative axis opening. Okay. I'm going to prepare a conservative lingual axis opening, or conservatively, I am going to prepare a class 3 or a class 4 cavities. Means I don't want a direct access. Normally, axis opening, definition of axis opening is providing direct access to the coronal, from the coronal reference point to that of the apical point. That is what the axis opening, straight line axis it is basically. But due to modern endodontics, and we have night eye files which are flexible, you have irrigation solutions which can reach at any corner, like self-existing files, SAFs are there, endovacs are there. There are so many advanced things. In this advanced endodontics, you don't require direct access to that of your apical foramen. So that is the reason why even if it is a class 3 or a class 4, by doing a conservative preparation, you can make an access. Okay. With this minimalistic preparation, you can simply go for a composite restoration. No need to go for a crown in all the scenarios. That is what it's telling. So it's very, very frequently asked question. Okay, what could be the post-endodontic restoration for a minimal crown loss in the anterior teeth? Your answer is simply go for the composite basing upon the requirement. A very, very frequently asked question. Now, whenever it is moderate to extensive loss, again, very, very important key point, less than half of the residual tooth structure. Whenever the leftover tooth structure is less than 50%, in such scenarios, I'm going to go for a post. Okay, I'm going to go for a post. That could be a fiber post or a metal post followed by full crown I'm going to go for. Whenever more than 50% or whenever it is equal to 50% residual tooth structure, and you're expecting a less functional stress over that particular area, I'm going to build a core and followed by a crown. Whenever by mistake, if you have more functional stresses, in such situation, I can go for a post-end core followed by a crown. And I hope you guys are very, very clear. So what is the criteria basing upon which I am going to decide whether to go for a composite restoration or a regular core or regular post-end core followed by a crown in anterior teeth is basing upon the amount of tooth structure that is left over. Whenever the loss is very, very minimal, I'm going to go for composite. Whenever the loss is moderate to excessive, basing upon the amount of tooth structure that is lost and basing upon the functional stresses, I'm going to decide what post-endo I'm going to give. So this is the first and foremost important concept. I want every one of you to make a note. Guys, clear? I just need your response in the chat box so that I'll be moving to the next important topic. So it's very, very simple, right? So next I'll be talking about pressures in pulp, because pulp, you know, if you see the structure of the pulp, you will be having an outer enamel coating, and followed by inner you will be having a dentin, and followed by your pulp is being encapsulated by the dentin, surrounding the dentin. So pulp is a closed chamber. Whenever something is a closed chamber, the closed chamber is going to exert pressure, and that particular pressure is called as pulpal pressure. So that particular pressure is called as pulpal pressure. And questions on pulpal pressure and questions on pulpal nerves and questions on pulpal collagen are very frequently asked areas. Okay. So first I'll be talking about the normal pulpal pressure. Anyone? What is the normal pulpal pressure? So normal pulpal pressure is 5 to 10 mm of Hg. It is 5 to 10 mm of Hg. Okay, if they're asking in Hg. Or they can ask you in centimeters of saline. If they're asking centimeters of saline, it is 10 to 15 centimeters of saline or water. It is 10 to 15 centimeters of saline or water. So this is a normal pulpal pressure. Can you correlate these values of pressure to any other pressures in the human body? Integrated, right? So we are going to go to an integrated session. Okay. So the same values are seen in the other part of the body also. Okay. There is something called as portal hypertension. Portal pressure. Portal pressure is the pressure which is seen in the case of your portal system, hepatic system, liver. Okay. So that is called as portal pressure. So there is something called as portal pressure. So portal pressure and pulpal pressure values are same. Both of them starts with P. Both of them, they starts with P. So one is portal pressure. Second one is pulpal pressure. Second one is pulpal pressure. So both of them, they starts with P, and both of them, the values are same. Okay. Both of them, they starts with P, and both of them, the values are same. One is pulpal pressure. Pulpal pressure value is 5 to 10 mm of Hg. And the second one is portal pressure. Portal pressure value is also 5 to 10 millimeters of Hg. 5 to 10 millimeters of Hg. Okay. Right. You guys are right. Okay. Next one. What is the pulpal pressure value in the case of irreversible pulpitis? And what is the pulpal pressure value in the case of reversible pulpitis? Okay, so we have a condition called as reversible pulpitis. We have a condition called as irreversible pulpitis. A very frequently asked question is, what are the values of the pressures whenever you have such condition? Okay, so first and foremost thing is reversible pulpitis. Reversible pulpitis will be reversing back if the stimulus is being removed. So that is a diagnosis, means tingling like sensation, sharp pain, which subsides immediately after the removal of the stimulus. Your answer is reversible pulpitis, which does not subsides and extended over a period of time of 10 to 15 seconds. That is called as irreversible pulpitis. So reversible pulpitis, the answer is 13.5 millimeters of Hg. Whereas irreversible pulpitis, the answer is 34.5 millimeters of Hg. So these are the values which are again very frequently repeated areas of NEET and INICET. Okay. Now my question is, so we have learned about portal pressure. So what is called as portal hypertension? Portal hypertension. We know normal hypertension whenever your blood pressure is being increased 120 by 80. So portal pressure is whenever the value, because we learned the value is 10. So whenever this value is more than 10 millimeters of Hg, whenever this value is more than 10 millimeters of Hg, that particular condition is called as portal hypertension. And of course, in GS we have discussed. Okay, so there is varices formation will occur in the case of portal hypertension. So at what pressure varices are seen in the case of your portal pressure? Your answer is more than 12 millimeters of Hg. more than 12 millimeters of Hg. So these are the most important things that you have to make a note when I'm talking about the pressures. So I'm done with pressures. I'm moving to the next part. Anyone can tell me what is the pressure in the case of your necrotic pulp? Necrotic pulp. What could be the pulpal pressure in the case of necrotic pulp? Necrotic pulp is dead pulp. So whenever the pulp is dead, there is no pressure. Okay, so the answer is 0. Now I'm moving into the nerves. So basically, your pulp is going to have nerves, and the stimulation of this nerves is going to cause pain. So normally in the entire human body, the pain causing fibers are the same fibers which are present in the pulp. So you have a different fibers in the human body: A alpha, A beta, A delta, A gamma, C fibers, B fibers, and everything. Out of these fibers, the fibers which are going to cause pain are C fibers, which are going to cause pain are C fibers and A delta fibers. And those are the fibers which are present in the dental pulp. So now they can ask you a question. The extra fibers, apart from C fibers and A delta fibers, which are the predominant fibers which are present in the dental pulp, apart from these two, there is one more category of fibers which are very, very rare or which are very, very limited. They are also seen. The predominant fibers in the dental pulp are C fibers and A delta fibers. Apart from this, we regularly see A beta also, but it is very, very less. Very less amount of A beta fibers are seen. Now, C fibers are present in the center. You can easily remember C for center or C for core. C for center, C for core. C fibers are present in the center, and their diameter is 0.3 to 1.2 micrometers, and the velocity with which the nerve fiber conduction occurs is 0.4 to 2 millimeters per second. It's very, very important. Questions were given in INICET on these values. C fiber present in the center. So diameters are important, velocities are important. Okay, right. And these C fibers are unmyelinated fibers. They don't have myelin sheet on them. So that is the reason why C fibers react fast to local anesthesia. No myelin sheet. Nothing is covering their body. So whenever you drop LA, it's easily absorbs. Okay, myelin sheet because it acts as an insulator. So that is the reason why first fibers which react to local anesthesia are C fibers, because they are unmyelinated. They don't have myelin sheet. The next pain causing fibers are A delta fibers. And these A delta fibers are present in periphery, surroundings. C fibers are present in the core. A delta fibers are present in the surroundings. And coming to the diameters, diameters are very important. So this is an exact value which is given in INICET. This is an INICET repeat. Velocity of A delta fibers in the dental pulp is 6 to 30 meters per second. And this motion is basically due to, one is because of diameter, and second one because they have a myelin sheet on them. So covering myelin sheet is there on them. So whenever you have a myelin sheet, we have saltatory motion of conduction. Okay, we have saltatory motion of conduction whenever you have a myelin sheet. So what is the mode of fiber? Again, mode of pain is a very frequently asked question. Short, well localized, sharp prickling pain is seen with A delta fibers, whereas dull, poor localized throbbing pain is seen in the case of C fibers. This is what the exact lines which are given in NEET 2022. Can anyone tell me the latest question in the NEET? Okay, which fibers have capability of giving a referred pain? You know that the pain is basically moving around C fibers. One is basically moving around two types of fibers. One is A delta fibers and second one is C fibers, right? So you have two types of fibers which are causing pain. Among these two types of fibers, can you tell me what is a fiber which is responsible for referred pain? The answer is C fibers. C fibers are responsible for referred pain. It's very simple, straightforward question. Which of the following fibers are associated with the referred pain? 2025 NEET question. The answer is straightforward, simple, C fibers. It's a NEET 2025 question. So I'm done with the fibers part. Okay, right? And we know that, I mean, like you know that we are going to do pulp sensibility tests. So there is a misnomer that pulp vitality. So we don't do vitality tests in our departments. Those tests, whatever we are going to do in the departments, are basically pulp sensibility test. Means you are checking the nerve supply. You are checking the nerve supply. And most of these fibers most of these pulp sensibility tests like cold test, heat test, electrical pulp test, and whatever these tests are basically checking the nerve supply. What nerves they are basically targeting? They are basically targeting A delta fibers, primary A delta fibers. We are checking only A delta fibers. Okay. Sometimes there is a word called as biphasic stimulation. Means, for example, if a question is given, which type of nerve fibers are activated in the case of your heat test? A delta. Which type of nerve fibers are activated in EPT? A delta. Which type of nerve fibers are being activated in the case of your cold test? Answer is Answer is A delta. Okay. Sometimes what happens is whenever you do heat test for a prolonged duration of time, normally heat test should be done within 5 seconds. Sometimes if you do prolonged heat test, then you will be having called as biphasic stimulation. Means initially it is going to stimulate A delta fibers and followed by C fibers will also get stimulated. Normally in majority of the vitality tests, we don't activate C fibers, we activate A delta fibers only. But sometimes because of prolonged heat test, you have this biphasic stimulation that is seen in the case of your heat test, where both A delta fibers as well as C fibers are going to get activated. Here I want to explain one important clinical area, why a very frequently asked Viva question for you in pedo departments is, are you going to do vitality tests, or simple in our terms, pulp sensibility tests like heat test, cold test, EPT and all these in primary kid or not? Are you going to do this in primary teeth? Or you're going to do this in pedo, in a pedo department? Do you use this vitality test? Yes or no? I just need your response on the chat box. Do you really do this? Okay, because here in this concept, we have clearly discussed in majority of this viability test, I'm activating A delta fibers. And these A delta fibers are basically, they are called as myelinated fibers. They are myelinated fibers. They have myelin sheet on them. Without myelin sheet, it is not called as A delta fiber. So normally, okay, fibers will be generated, and normally you see the term, exact term in the textbook is primary teeth and young permanent teeth. Primary teeth and young permanent teeth, they don't have this myelin sheet, because a teeth will take at least 4 to 5 years. This is what the exact lines which are given in the exam. A teeth will take 4 to 5 years after their eruption into the oral cavity to generate or to produce myelin sheet. Means myelinization of nerve fibers are going to occur after 4 to 5 years after the teeth that is erupted into the oral cavity. So that is the reason why strictly in primary teeth and in young permanent teeth, I'm not going to do this sensibility test. The reason why I'm not going to do this sensibility test, it is very simple. The answer is no myelin sheet. No myelin sheet means your myelinization is not happened properly for your A delta fibers. Whenever your A delta fibers myelination sheet is not happened properly, then you are not eligible to do this particular test. A very, very important frequently asked question. 4 to 5 years is also given as a question. My reason why I'm not doing this test is myelin sheet is not being formed. Okay, again, this is a very, very frequent area, combination of pedo and endo. And I hope you guys are very, very clear why sensibility tests are contraindicated in the primary teeth and young permanent teeth. If a question is asked in the Viva in your final year also, you can straight away answer. The reason is for a teeth, the nerves which are present in the teeth will take at least 4 to 5 years after their eruption into the oral cavity for myelination to happen. So no myelin sheet, no A delta fibers, no A delta fibers, you are not stimulating the fibers which are primarily responsible for your pulp sensibility test. I hope you guys are very, very clear. Right. Okay. Right. So if you're done, I'll be going to the next part. Next important area I'll be focusing on. Can anyone tell me what are the types of, because I was talking about nerves. Again, collagens are important. Collagen is very, very frequently asked area for us. So what is the type of collagen which is present in the dental pulp? What is the type of collagen which is present in the dental pulp? Collagen is the most common protein that is present in the body. In the body, the most common protein in the body, in the entire body is collagen. Most common type of protein that is present in the teeth. is again collagen, and most common type of collagen that is present in the teeth, the answer is type 1. Only structure in the dental structure which is not having collagen is enamel. Enamel does not have collagen, whereas others are going to have collagen. Predominant collagen in dentin is type 1. Predominant collagen in cementum is type 1. Predominant collagen in pulp is type 1. Predominant collagen present in PDL is type 1. Predominant collagen which is present in alveolar bone is also type 1. Everywhere the answer is type 1 only. Type 1 is predominant. Now, I'll talk about exceptions. For example, anyone? Mantle dentin, very specifically if they ask, mantle dentin, what should be your answer? Cartilage, cartilage is type 2. Mantle dentin, your answer is type 3. You have something called as bank of fibers in mantle dentin, which are going to have type 3 collagen. Okay. Similarly, okay, so if they're asking the second type of collagen which is present in the pulp, answer is type 1, type 3. Type 1, type 3. PDL, type 1, type 3. Dentin, type 1. Mantle dentin, type 3. Cartilage, type 2. Basement membrane is type 4. Basement membrane is type 4. I don't want to go deep into this histology part, which we'll be discussing there. But here I want to address the pulp. Pulp is going to have predominantly type 1 and type 3 collagen. Which is predominant? The answer is type 1. For example, if a question is asked long back, this is a repeat from one of the book that few of you are going to do it. This is called as Manisha Prabhakar repeat. A trend 10 years back, not now, most of you are not doing this. There you have one question called as type of collagen present in the fetal pulp. Type of collagen present in the fetal pulp. Okay, because Manisha Prabhakar is a book long back done for AIIMS. Okay, because there are few questions which are straightforward repeated from AIIMS, now not required, but on a safer side, because you may be solving questions from different apps. So fetal pulp, what is the type of collagen? Answer is type 3. Normal pulp, type 1, type 3. Predominant type 1. Fetal pulp, answer is type 3. I hope this is done. Okay, I don't want to go very deep into that particular concept. Now I'll be jumping into one important area, pulp capping. Okay, I hope you guys know the basic criteria to go for pulp capping, and which is very common scenario. Okay, so I will just ask you a basic genuine question at a BDS level. So I mean, including me as a BDS student. Okay, so whenever I was being posted in third BDS in my operative dentistry department, or in my fourth year in the same department, so whenever I have a case, deep caries management, upon I'm removing of dental caries, so there is a sudden pinpoint exposure of pulp. Pinpoint exposure of pulp. With a BDS third year, final year student, pinpoint exposure of pulp, according to textbooks, according to studies, can you do pulp capping there? Yes or no? Can you do pulp capping there? Keep on digging. Suddenly, pink point, mechanical exposure, pink point. You have seen at a BDS level. Considering the methodology of dentistry in colleges, according to studies, is that case an ideal case for doing pulp capping or not? I see most of you are telling yes. Don't feel bad. Okay, absolutely you should not do. Reason why you should not do, because isolation is very important whenever you're going for direct pulp capping. These were the studies which are clearly showing. Okay, most important thing is isolation. Second important thing is controlling the bleeding. If you are able to do these two things, then you can proceed with the pulp capping. Okay, right? So isolation, but I feel like most of us will not do isolation. Isolation is not isolation with the cotton rolls, isolation with a rubber dam. Proper sealed isolation with a rubber dam should be there, because the mode of transfer, whenever the pulp is exposed, whenever the infection is there, it spreads easily through the blood. The easiest way of spreading of infection into the pulp is blood spread. Blood will make it very quick. Okay, right? So keeping your limitations, the most commonly used material long back for pulp capping is your calcium hydroxide, also called as dicol. Normally, the difference between the normal calcium hydroxide and dicol calcium hydroxide is dicol calcium hydroxide is fast setting. It sets very fast. I hope you guys have seen it. Okay, uh, when you are setting dicol, and second one is fast setting. It sets fast. It is going to set hard and fast setting. Calcium hydroxide is basically called as dicol. But now the trendy material which is ruling the entire endodontics is going to be your MTA. Okay, now the most common material with a good success rate, good outcomes, great results. The answer is MTA. You have MTA, no need to consider your calcium hydroxide. You can easily jump into MTA as the answer for most of these questions. Okay, now I have a case scenario in front of me. Cases, different types of cases. Leave about diagnosis because today's class is not about diagnosis. It's about doing a case. Okay, it's about doing a case. Now, I have a case, a pediatric kid of ACE, of trauma, of this condition, that condition. So you have lots of packed stuff that is being given in your questions. So whenever you have a case-based question and you have to plan a treatment plan according to the treatment plan for that particular question, okay, make sure, please try to identify these lines from the case. First thing, any case, pediatric endodontics, endo case, options filled with pulpotomy, pulpectomy, basic RC, apexogenesis, apexification, revascularization, all this, wherever you see this nonsense, first thing is from the info which is given in the question, underline the keywords and get these two information. Information number one, in the case, I want you to know the status of the pulp. In the case, I want you to know the status of the pulp. What are the two statuses of the pulp we have? One is vital pulp. Second one is non-vital pulp. Okay. So in the case, first decide, basing upon the info, whether the pulp is vital or non-vital. Very, very important to eliminate the options. Very simple it is. Vitality can be known by the description that is being given. Non-vital can be known by the description that is being given. The teeth does not respond to heat test. The teeth does not respond to cold test. The teeth does not respond on EPT. EPT is very frequently asked. Teeth does not respond to EPT, non-vital. Sometimes they are not going to give the vitality. They'll tell that the teeth is discolored. Discolored teeth compared to adjacent teeth. Yeah, it is because of pulpal necrosis, non-vital. That is what the question that is given in NEET 2025. Not mention vitality, simply tell that the discolored teeth. Discolored teeth means dead pulp, non-vital. So check whether the teeth is vital or non-vital. One important clinical condition they can indirectly tell the vitality is by giving the discoloration. If discoloration is present, it is non-vital. The second most important thing is check out whether the teeth is having an open apex or a closed apex. Whether the apex is open or closed, because open apex treatments are different, closed apex treatments are different. How you will know an open apex or closed apex is by knowing the age of trauma. Very, very important point. It's not the age of the patient. It is age of the patient. It is the age of the patient during trauma. It is the age of the patient during trauma. Simple funda, I want you to make a note. Keep 10 years as a target because most of your questions moving around the trauma to maxillary anteriors. So whenever the age of the patient is less than 10 years, okay, it is open apex. More than 10 years or 10 years closed apex. Clear? Whenever age, for example, now the twist is a patient of age 11 years came to your department with a discolored anterior teeth, gives a history of trauma 4 years back. Now what you have to take? You have to take whether it's an open apex or closed apex. So age of the patient is 11, but trauma has happened 4 years back. So now the age of patient during trauma is 7 years. 7 years, your answer is open apex. Okay, the most important thing to be noted is whenever you have an open apex, whenever you have a closed apex, the most important thing to be noted is age of the patient during trauma is indirectly going to tell you whether it's an open apex or closed apex. One. Second most important aspect is sometimes they're going to give you a radiograph. So in radiograph, you are going to check it whether it's an open apex or closed apex. Two categories. One is age of the patient during trauma. Second one is they are going to give a radiograph. You'll get the info. Third is they're going to give the description of the radiograph. Upon radiographic examination, we found that there is an open apex with periapical lesion. So by which you are going to get an information about open apex or case closed apex. So these two things are most important. Vitality, vital or non-vital. Next, age of the patient during trauma, to know whether it is an open apex or closed apex. So if you have information of these two, you can easily answer the question by elimination. Okay. And again, I'm telling, so it's not always mandatory to go for an ideal treatment. It's always advised to go for the best treatments among the four options. You have four options in front of you. So among the four, what is the best with your knowledge? So you need to know the vitality. You need to know the apex, closed or open apex. Okay, so that is how you're going to solve most of the questions. We'll try to address few important areas. Apart from this, there are areas where you have restorations of choice. Okay, right? For example, cervical aberration. The restoration of choice for cervical aberration is GIC. The restoration that is done in tunnel preparation, operative dentistry, GIC. Again, angle of burr during tunnel preparation. Angle of burr during tunnel preparation 45 degrees. ART, GIC. Cervical aberration, GIC. Tunnel preparation, GIC. Root caries, GIC. Root caries is also called as cementum caries. Root caries is most commonly associated with gingival recession, most commonly seen in the older individuals, also called as cementum caries. Most rapidly progressing caries is going to be, one is rampant caries, again root caries is also very anatomically most rapidly spreading caries is going to be root caries. And other important point to be noted about the root caries is U-shaped cross section is seen in the case of U-shaped cross section is seen in the case of which type of caries? The answer is root caries. The answer is root caries. Okay, guys, I hope it's very, very clear. Now, right, so what infos we got? Information number one, vitality, vital or non-vital. Indication number two, condition of apex, open apex or closed apex. Chalo, we got these two informations. First thing is, like, whenever you have a deep caries lesion, normal pulp, everything is normal. We go for deep caries management. Deep caries management I'm going to do. Very important in your clinical practice also. But nowadays, you see, if you are not able to do deep caries management properly, the cases are going for root canal therapy, which is going to be difficult for the patient financially, and which is going to be an advantage for the clinician financially. But it is deep caries management is going to be the key factor of your entire clinical practice in the future. Okay. So in the deep caries management, you're going to do a normal deep caries management, or in some cases, you can extend this deep caries management to pulp cappings. So in deep caries management, vitality of teeth is vital. In pulp capping is a dental vital procedure. It's a pulp vitality procedure. It's a vital procedure of pulp. So whenever you're going for pulp capping, indirect pulp capping or direct pulp capping. So in both of these conditions, the pulp should be vital. Okay, so it's a vital procedure. Means pulp cappings are going to come whenever the patient is in front of you is having a vital pulp. Okay, right. So now most important point is, I don't want to stretch about this indirect pulp capping. So I'll jump into direct pulp capping. So you have a direct pulp capping case in front of you. And most of the common terms that are given in direct pulp capping are mechanical exposure, pinpoint exposure, mechanical exposure, pinpoint exposure under proper isolation with rubber dam, and you're able to control bleeding, and the size pinpoint is size is less. In such conditions, you are going to consider pulp capping. Even if you are not able to control the bleeding, if you are not able to control the bleeding, okay, so what is going to happen? I'm not going to go for such procedures. I'll be going for a more invasive procedure. I should stop the bleeding with the cotton pellet or something. I should stop the bleeding. Then the patient should get settled. Then I'll think about going for direct pulp capping. Okay, so that is most important thing. So these are the key terms which will be given in the case of your direct pulp capping. And one important thing is, like, for example, if you check out the studies and everything about the pulp cappings and everything, long back, couple of years back, according to American Association of Periodontics, they said not to do this direct pulp cappings in the case of your primary teeth. Okay, long back. Primary teeth, better go with pulpotomy. Better go with pulpotomy rather than direct pulp cappings whenever you have a mechanical exposure. And the reason they have coded, which was given as a question for us in INICET, is because of more blood supply. Primary teeth is going to have more blood supply when compared to that of the permanent teeth. Because of more blood supply, the mode of infection is going to be fast. But in the recent articles and everything, they have changed this. The reason is same. When I'm comparing the primary teeth to permanent teeth, pulp cappings are going to fail more in the primary teeth. The answer is this. But it's not absolutely contraindicated. If you want, you can do. If fails, you are going to go for the next level of procedure. But now primary teeth, according to American Association of Periodontics also, if you want, you can do with, if you want, you can go with the pulp capping procedures. If you want, you can go with the pulp capping procedures. Okay, right? So direct pulp. So direct pulp capping, I'm going to go. In this direct pulp capping, okay, the best material is going to be definitely MTA when compared to calcium hydroxide. The usage of calcium hydroxide has dropped down. So whenever you see MTA option, you can go for MTA. Then goes the next level of procedure is pulpotomy. Okay, so I'm going to do pulpotomy. Pulpotomy is partial removal of pulp. Okay, not completely. Pulpectomy is complete removal. So whenever I have a closed apex, I'll think of going for pulpectomy. Whenever I have an open apex, for apexogenesis to happen, I'm going to leave some sort of vital. So pulpectomy is a non-vital procedure. Pulpotomy is a vital procedure. So by which, when to go for pulpectomy, when to go for pulpotomy, if you know the vitality of the patient, pulp vitality of the patient, you can easily differentiate. Because pulpotomy is a vital procedure. Whenever the teeth is having vital pulp, apexogenesis is going to happen. Whenever the teeth is not having vital pulp, then you can go for pulpectomy or apexification. Okay, right? So again in pulpotomy, if you're talking about pulpotomy, again in pulpotomy, the best material is formocresol pulpotomy when compared to that of the calcium hydroxide pulpotomy. Okay, right? Why calcium hydroxide pulpotomy can lead to internal resorption compared to formocresol pulpotomy, because formocresol is going to have lots of toxicity on the brain cells. There are studies showing that the formocresol has created some impact on the brain tissue. We have better materials like MTA, biodentin, and all these materials are doing little better. Okay, so if you have MTA, biodentin in the options, go for it. If you don't have this, then think of formocresol. The last option we are not encouraging to do is calcium hydroxide because of the internal resorption. So these are the important things about direct pulp capping and pulpotomies, which are basically vital pulpal procedures. Okay, so till now we have discussed about vital pulp. Now I'm jumping into non-vital pulp. Non-vital pulp is nothing but necrotic teeth. Non-vital pulp is nothing but necrotic teeth. In non-vital pulp, clinically, what they can give as a discoloration. Discoloration is basically due to necrotic pulp, necrotic teeth. So I have a non-vital pulp. Now, okay, now I'm going to go with the flow chart. Okay. So non-vital pulp are basically, you have the traditional endodontics. Traditional endodontics, whatever endodontics we are practicing is traditional endodontics till now. With advanced tools, I'm practicing the traditional endodontics. Okay. What happens whenever I have an open apex? Traditional endodontics, open apex, traditional endodontics, closed apex. In an open apex case, I'm going to fix the open apex. That is called as fixation. That is called as fixation. Whenever it is closed apex, normally apex is closed by apexogenesis. Genesis, you can remember Genesis, G for God. Okay, who is going to close the natural way of closing the apex is called as apexogenesis. Apexogenesis, who is going to close natural way the root apex is God. God is nothing but pulp. Okay, right? So Genesis is natural way of closing apex. Fixing, because I'm going to fix it. As a dentist, I'll be fixing it. Apexification is an artificial way of blocking the apex that is done by dentist, you and me. Fixing, you and me do. We are going to fix it. That is called as apexification. Genesis is done by God. G for G, God. Okay, right? So that is done by the dental pulp. Okay. So whenever it is a closed apex, what I'm going to do? My ace is, okay, your ace and my ace, all the teeth, the apexes are closed. We are going to go for RC, simple RC, adults RC. Very simple. For example, a child is coming with a trauma, information is given as open apex. I'm going to fix it. The problem with apexification, what is the problem with apexification? Apexification does not lead to thickening of the dentinal walls of immature teeth. No, it will not do that. Why it will do? Only God can do that. So there is a significant amount of tooth structure that is lost from traditional endodontics. That's what I'm telling. Like, we started the class telling that the most common reason for loss of tooth structure is basically your coronal preparation, axis opening. Traditional endodontics, axis opening preparations are destroying the most amount of tooth structure. So both of them, those are the main reasons or problem with apexification. So I need to find a solution for this. So then your regenerative endodontics came into existence. What is this regenerative endodontics telling? The regenerative endodontics is telling for an immature apex. For an immature apex, what I'm going to do? I'm going to go for revascularization. What is this revascularization? Pulp is gone. So what I'm doing is I'm trying to develop pulp-like tissue. Pulp-like tissue. Okay, so whenever I have a pulp-like tissue, pulp has the capability of generating the dentin. Okay, so open apex is there. Now what I have done regeneration. So now I have, my pulp is lost. Now I have done regeneration, my pulp is back. Now the pulp job, the God is back again. Whenever the God is back again, root closure starts. So root closure, slowly closure of the root is going to occur. Okay, right guys, clear? So these apexes, like matured apex modern endodontics, are still under research. What are they? Stem cell therapy I can do. Pulp implantation I can do, means I can extract third molar rudimentary, take that pulp and implant that particular pulp, like how I'm going to do heart transplantation, liver transplantation, everything. I'm going to extract the pulp from there and I'm going to insert the pulp here. Or scaffold implant gene therapy I can do, but most of these things are under research. Guys, you are clear with this? What is traditional endodontics? Open apex, closed apex. What is regenerative endodontics? Open apex, closed apex. Mature apex, no, not in research. So they may not ask questions on that particular area for us. Okay, clear, done. So now I'll be giving a set of, okay, right? So we have discussed something called as apexification. So material which is useful for apexification, Apexification single visit is basically done with MTA, and the thickness of MTA that is done in apexification is 5 millimeters, and multi-visit apexification is done with calcium hydroxide. Okay, multi-visit calcium hydroxide, single visit MTA, best material MTA. Okay, right? So best material for direct pulp capping. What is your answer? Best material for direct pulp capping. Best material for direct pulp capping, the answer is MTA, followed by any other material. Calcium hydroxide has some disadvantages, like it has a layer of necrosis layer will be there, coagulative necrosis layer will be there, and tunnel defects will be there, which can lead to micro leakage and secondary caries and failure of the restoration or failure of the treatment therapy. So MTA is best over there. When I'm talking about pulpotomies, again, MTA biodentin are going to be best, followed by pharmacrisol pulpotomy, followed by the least is going to be calcium hydroxide pulpotomy, because calcium hydroxide pulpotomies are basically associated with internal resorption. Similarly, if I'm talking about apexifications, again, the best material is going to be MTA, because you can do it in a single visit, single step. And multi-step apexification is basically done with calcium hydroxide. Success rate is more with MTA. Thickness of MTA in the case of your open apex cases is 5 millimeters. With which I'm done with this. Okay, right? Now I'm going to give you a combination. Okay. Non-vital teeth. Non-vital teeth. Okay, I'll try to project in a case scenario. A 10-year-old boy approached your OPD with a discolored anterior teeth. And gives a history of trauma. 3 years back. Okay. Now, what is the best procedure that you are going to do for this particular patient? Whenever you have a question like this, I told you to go back with two important things. One is vitality, second one is open apex or closed apex. Vital or non-vital? Vital or non-vital? Vital or non-vital? So this is a non-vital case. Yes, someone is telling regenerative endodontics. Navya is telling apexification. Apexogenesis is not going to happen. There is no God. I told you, apexogenesis, God should be there. No God, because it's a non-vital teeth. Because discoloration is there, vitality is non-vital. And coming to open apex or closed apex, I told you the age of the kid is 10 years, trauma 3 years back. So 7 years, it is an open apex case. It's an open apex non-vital case. In an open apex non-vital case, right? So I'm going with my flow chart. So you have flow chart in front of you. Necrotic teeth, yes, chilo, non-vital. I'm going to come for this table. Now it's an open apex. So I can go traditional endodontics, I can go apexification, but I have a disadvantage of apexification. In modern endodontics, I can do revascularization. So both are right. Apexification is right. Revascularization is right. If both options are there, your answer should be revascularization. That is what the question already given in INICET. Right? So here the best option is regenerative endodontics. If regenerative endodontics is not there, then you can go for apexification. Clear? You want me to throw one more question? One more combination of the question? You want me to give one more? Okay, one more question for you. Again, age of kid is 10 years. Okay, age of kid is, okay, 8 years. Age of kid is 8 years. And there is a recent trauma. There is a fracture of enamel, dentin, exposing the pulp. Pinpoint exposure of the pulp with an open apex case. Pinpoint exposure of the pulp with an open apex case. What is your treatment? Pinpoint exposure of the pulp with an open apex case. pinpoint exposure of the pulp. I told you to check out the vitality. Pinpoint exposure of the pulp. Probably it would be vital. So it's a vital case, but it's an open apex. It's an open apex. So what I'm going to do? What are you going to do? Yeah, I want genesis to happen. I want the god should be there. Who is the god here? Pulp is the god. So I'll be going for direct pulp capping. Pinpoint exposure, immediately shifted to the clinic. So I'll be doing a direct pulp capping. I'll be doing a direct pulp capping. If the incidence to that of your clinic visit is a little longer, not immediately reported, then you have to go for pulpotomy with MTA. Even with pulpotomy with MTA, even with direct pulp capping, you are maintaining the vitality of the pulp. Whenever the vitality of the pulp is there, pulp is God. Whenever God is there, closure of apex is going to happen. The closure of apex is called as apexogenesis. Apexogenesis is not treatment. It is the outcome. What is your treatment? In these two scenarios, your treatment, one treatment is direct pulp capping. That's a vital procedure. Second treatment is pulpotomy. That is also vital procedure. Outcome of these two procedures in this particular patient is closure of apex, that is called as genesis. I hope this is clear, with which I'll be moving ahead. As it is the initial day of endo, I'm going a little slow even in the bootcamp series, because reason why I'm going little slow in this particular concept of bootcamp series is, in the last couple of days, I see so many of you are messaging related to these concepts in pedo, because they are again inclined to pediatric endodontics. So the last subject is pedo. I see most of you are messaging on a daily basis. That confusions, people are messaging me. So that is the reason why I'm going a little slow, right? Done? Okay, chalo, right. So now we will look into regenerative endodontics notes, okay? How we are going to do and everything, because there are many questions on this particular area, regenerative endodontics, okay? So whenever you have a case of regenerative endodontics, so this is how you are going to select a case of regenerative endodontics. Guys, make sure you do subscribe the channel and keep your bell notification on for all the important updates, because in the next couple of days, the team has decided to post all the repeated questions in the discussion format on YouTube regularly, or we are planning to post the questions on YouTube, okay? YouTube post in the post format. So that is going to be a good exercise for you. Make sure, even if you're watching this as a recorded version, you keep your bell notification on and subscription to the MDS CONQUER channel for all the updates related to dentistry, all the updates related to various license exams, opportunities and everything will be posted on the MDS CONQUER channel and Instagram page. Make sure you keep your subscriptions on for that particular area. So now I have a case. Which case I have to go for regenerative endodontics was a criteria which is given. I told you regenerative endodontics is done in a non-vital teeth, necrotic pulp, in an open apex. So that is the most important thing. Whenever you have an open apex case with a necrotic pulp, you are going to do regenerative. Pulpal space that does not require post and core or final restoration. Okay, that does not require post and core or final restoration. There should be cooperation of the patient and the parent, because regenerative endodontics is a multi-visit. Even if you see the same line for your serial extractions are also multi-visit, okay? So the most important criteria for the success of serial extraction is the patient and parent cooperation, because they have to come for the multiple appointments. Similarly, here in regenerative endodontics also, the patient has to come for multiple appointments, and patient should not be allergic to the medications or antibiotics that are used to complete the procedure. So these are the 4 criteria which is given according to American Association of Endodontics, which are very, very important. So you have questions on this area in INICET. Now in the first appointment, what I'm going to do, I am going to give local anesthesia. I'm going to apply rubber dam isolation I'm going to do, and I'm going to open the axis. So once I open the axis and start my procedure, okay, so what is the methodology of working length? What is the methodology of working length determination in the case of open apex case? The methodology of working length determination in the open apex case is paper points. So, which of the following method is used to determine the working length in the case of your open apex? The answer is paper points. Normally, the best method of determining the working length, anyone? The best method of determining the working length. Best method of determining the working length, if it is a single method, the answer is apex locators. The answer should be apex locators. If they're asking a combination method, then your answer is a combination of apex locator confirmed with a radiograph. It is basically a combination of non-radiographic technique plus radiographic technique. Apex locator is non-radiographic technique. Okay, and any of the radiographic technique you can use. And I hope most of you are aware of different types of technique: Grossman's technique, Wien's technique, Knudsen's technique, and all these are different types of techniques of determining the working length. Normal basic technique should be 0.5 to 1 millimeter short of your radiographic apex is the working length determination. So can you tell me what are the conditions where your apex locators are contraindicated? Conditions where your apex locators and EPTs are contraindicated. Condition where your apex locators, normally the most common method is apex locator or apex locator confirmed with a radiograph, but there are conditions where your apex locators are contraindicated. One condition where apex locators are contraindicated, apex locators and EPTs are contraindicated is pacemakers. Cardiac pacemaker patients, I'm not going to use apex locators. Cardiac pacemaker patients, I'm not going to use EPTs. Apart from this, open apex cases, apex locators are not going to work. So that is the reason why in open apex cases, what I'm going to do, I'm going to use paper points. Method of determining of working length in the case of open apex cases is paper points. Okay, right. Now I have opened it. Irrigation was done. So what I have done, 20 ml of NaOCl using irrigation system that minimize the possibility of extrusion into the periapical space. So normally the amount of NaOCl that I'm going to use in a normal scenario, okay, the percentage in the normal scenario is going to be 2.5 to 5.2. Normal range is 2.5 to 5.2 according to Grossman. Okay, so NaOCl normally is the most common irrigation solution that is used, and the range is 2.5 to 5.2 percentage. According to Engel, it is 6 percentage. But in this scenario, in this particular scenario, what I'm doing, I am using a less concentration. So in regenerative endodontics, the amount of NaOCl I'm going to use is 1.5 percentage. Can anyone tell me what is the percentage in the case of Dakin's solution? Solution which is used during world wars to clean the wounds. Anyone? What is the percentage of NaOCl in the case of your Dakin solution? What is the percentage of NaOCl in the case of your Dakin solution? Dakin solution is 0.5 to 1 percentage. Dakin solution is 0.5 to 1 percentage. So all these are NaCl numbers. Normally 2.5 to 5.2, Engel 6 percentage, regenerative endodontics is 1.5, Dakin solution is 0.5 to 1 percentage, 0.5 to 1 percentage. And again, in the case of your COVID tunnels, during your COVID tunnels also they have used this. Again, in COVID tunnels, the answer is again 0.5 to 1 percentage. During COVID tunnels also, for disinfection, they have used NaOCl. So now what I have done, I have used NaOCl, lower concentration. And this is also a question which is given in INICET. Irrigation needle should be positioned 1 millimeter from the root end. So I'm going to dry with paper points, determine the working length with paper points, dry with paper points. So now I'm going to give an intracanal medicament. Either I can place calcium hydroxide or either I can place triple antibiotic paste. And make sure it is a lower concentration triple antibiotic paste. And this concentration was also given in INICET. Lower concentration of triple antibiotic paste I'm going to use, and mix is also given 1:1:1 ratio of ciprofloxacin, metronidazole, and minocycline. Ciprofloxacin, metronidazole, and minocycline. And we are well aware that this minocycline is going to cause discoloration. And in modified triple antibiotic paste, this minocycline is being removed and it is being replaced by cephalosporin. So that's the difference. Reason is discoloration. And here you have a key point, right? Again, a conceptual question can be asked for you guys. Okay, sealing the pulpal space with dentin bonding agent. Why I'm sealing the pulpal space with dentin bonding agent? Sealing the pulpal space with dentin bonding agent. Why I'm doing that? Anyone? Just respond me on the chat box. Sealing the pulpal space with dentin bonding agent. Why I am sealing the pulpal space? Sealing the dentinal tubules. Why I need to seal the dentinal tubules? I'll be removing this triple antibiotic paste, right? I'm removing this triple antibiotic paste. What is the point of doing that? Any smart people? Please try to apply some logics. This is the reason why what I am doing it. I am blocking the dentinal tubules, so that this minocycline which is present in the triple antibiotic paste is not going to enter, leading to discoloration. Main reason why I am sealing the area with triple antibiotic paste, sealing the area with dentinal tubules is to prevent the occurrence of discoloration. Reason here is it is preventing the occurrence of discoloration. Okay, right. Okay, right. So again, you have a very frequently asked question. So that is the final concentration. I told you it is low concentration. How much is the low concentration was again a question that is given for us in INICET. The answer is 0.1 milligram per ml. Please write down that 0.1 milligram per ml. 0.1 milligram per ml. 0.1 milligram per ml. And of course, after which I'm going to seal the entire cavity with a cavity. Okay, that is. So cavit is the one material I'm going to use in intermediate restoration, and the thickness of the cavit is 3 to 4 millimeters. In the last class, I have discussed about the cavit thickness, which is already a previous question that is given in your NEET examination. The ideal thickness of the cavit to maintain this standard micro leakage, to prevent the micro leakage, is 3.5 millimeters. Please write down that. 3.5 millimeters. 3.5 millimeters. Guys, stay tuned for next 2 to 3 minutes. I'll be back again. I'll be back again. Yeah, hi guys, I'm back again. Hope I'm audible and visible to you. I just need a quick response so that we will resume the session. Okay, so I have discussed in the last class of mine in the bootcamp series of FPD. So I have discussed. So in endo, I'm going to use a intermediate restorative material, okay, to seal the particular space and to prevent the micro leakage to occur. And this particular material is called as cavit, and the thickness of the cavit range is 3 to 4 millimeters. And the ideal thickness, if they ask in the format of question, because that is repeated long back in the NEET examination, the answer is 3.5 millimeters. Okay, right? So see, CAVIT, cavit, 3.5 millimeters. Range is 3 to 4 millimeters. Okay, so I'm done with my first visit. So I'm jumping into my second visit. So second visit will be 1 to 4 weeks after the first visit. And I'm going to use 3% of mupivacaine without vasoconstrictor. Guys, do you want to add any point related to mupivacaine? Any point related to mupivacaine? People who are done with the OS or people who are done with pharma LA? Any point related to mupivacaine without vasoconstrictor? Can you tell me a systemic condition where 3% of mupivacaine is the LA of choice? Can you tell me any condition where 3% of mupivacaine without vasoconstrictor is LA of choice? Yes, Nabia, right? The answer is hyperthyroidism. Hyperthyroidism. Okay, where I'm going to the local anesthesia of choice in the case of hyperthyroidism patient. The answer is 3% of mupivacaine without vasoconstrictor. Again, 3% of mupivacaine without vasoconstrictor is the LA of choice in the case of second visit of regenerative endodontics. Okay, right. So now why I'm doing this is because I need to induce the bleeding, because here I'm going to over instrument. I need to create the bleeding, but if I give LA with a vasoconstrictor, that will not permit me for the bleeding to occur. So then I'm going to do with 20%, 20 ml of 17% of EDTA. pH of EDTA is 7.3. 7.3 is the pH of EDTA. Okay. 17% I'm going to do it. Why I am doing EDTA here? Why I'm doing EDTA here is, why I'm using EDTA here is, EDTA is going to open the dentinal tubules. EDTA is going to open the dentinal tubules. Okay. And followed by EDTA is going to activate the growth factors. It's going to open the dentinal tubules and activate the growth factors, followed by I'm going to dry with paper points. I'm going to create bleeding with over instrumentation. And I'm going to stop the bleeding at 3 to 4 millimeters to allow 3 to 4 millimeters of restorative material. Followed by I'm going to keep MTA or calcium hydroxide as a capping material, preferably MTA as a capping material. And then over which I'm going to keep 3 to 4 millimeters of GIC as a restoration. Then I'm going to follow up the patient. Clinically, in the follow-up, what I'm going to do, I don't expect the patient should have pain, or if any swellings are there, they should resolve, or any sinus openings are there, they should resolve. Okay, right? And positive pulpal response. So I'm expecting a pulp-like tissue to get regenerated. So I'm expecting the pulp vitality to respond clinically. Radiographically, there should be decreasing in the radiolucency, increasing in the width of the root canal walls, increasing the length of the root canal. So this is radiographically I'm expecting, and this is clinically I'm expecting to happen. Okay, right? As we have something called as sinus tract. So in which endodontic diagnosis, sinus tract word is very, very important. Anyone? Which of the following diagnosis, sinus tract is mandatory for that particular diagnosis according to the recent classification of American Association of Endodontics? Sinus tract is mandatory for which of the following diagnosis? Sinus tract is mandatory for which of the following diagnosis? Yes, sinus tract is mandatory for diagnosis of chronic periapical abscess. Chronic periapical abscess. For a chronic periapical abscess diagnosis, sinus tract is mandatory. How I am going to trace this sinus tract? I am going to trace this sinus tract with the help of gutta-percha. So I'm going to check the sinus tract. I'm going to insert the gutta-percha. Preferably a 20 size gutta-percha is used. So I'm going to insert it until I get a resistance, and followed by I'm going to take a radiograph by which I'm going to diagnose the sinus tract. Very, 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 very important question. You have a question on this particular area in 2024 NEET examination. Sinus tract is very, very important for diagnosis of gutta-percha. Sorry, for the diagnosis of chronic periapical abscess. for the diagnosis of chronic periapical abscess. 20-25 size cones are regularly used. Okay. Next, jumping into few important single liners which are already given in the examination. One is working length of the instruments in endo. Working length of most of the instruments in endo is 16 millimeters. Okay. Orifice location and angulation are basically done by which instrument? Orifice location, angulation are basically done by which instrument? Orifice locations and angulations are basically done by which instruments? Orifice locations and angulations are basically done by an instrument called as DG16. What is this DG16? DG16 is a scientist name. That is David Green. And 16 is 16 millimeters is the working length. Okay. So this is basically useful in orifice locations and angulations. Okay. Similarly, you have a similar instrument which is basically helpful for the same purpose in the case of calcified canals, that is called as CK17. CK17 is used for calcified canals to orifice location and orifice angulation. Okay, right? Okay, as we came across calcified canals, can you tell me any burrs which are used in calcified canals? Any burrs which are used in calcified canals? There is something called as Muller's burrs which are used in calcified canals. Muller's burrs are used in the case of calcified canals. Any particular solution used in calcified canals? Yes, it is EDTA. Okay, it is EDTA. 17% of EDTA, 7.3 pH is used in the case of your calcified canals. Okay. Anyway, we'll learn what is active GP. Active GP is basically which you're adding something to make GP active. That can be GIC, that can be chlorhexidine, or that can be calcium hydroxide. What most commonly you encounter during your preparation phase in the MCQ format, because already given one time active GP was given. So that is basically GIC combination with GP, which we'll be discussing in the monoblocks. Okay, right? Next, very frequently asked question in the instrumentation is the tip angle of endodontic instruments, the range of tip angle in endodontic instruments. The answer is 17 plus or minus 15 degrees centigrade. Okay, now a little bit about disinfection, because disinfection is something like, it's not exclusively microbiology. Disinfection is going to be part of your preparation in every subject. Okay, so now I have autoclave. So can you tell me what are the parameters of autoclave? Anyone? Can you tell me what are the parameters of autoclave? Okay, so autoclave parameters, the standard autoclave parameters are 121 degrees centigrade, 15 lbs and 15 minutes. These are the basic standard numbers of autoclave. We have something called as flash sterilization, flash autoclave sterilization, because you want instruments to be fast given to you because patient is waiting. Then you can go for autoclave mode, that is called as flash sterilization. In flash sterilization, the numbers are going to be slightly varied. 134 degrees centigrade, 30 lbs, 3 minutes. This procedure will be done in 3 minutes. Wrapping wise, the difference is whenever I'm going for flash sterilization, I don't regularly wrap the instruments. Okay, so flash sterilization is 134 degrees centigrade, 30 lbs and 3 minutes, whereas normal standardization is 121 degrees centigrade, 15 lbs and 15 minutes. Okay, the next one is called as tenderlization, also called as intermediate sterilization, because I'm going to do sterilization for 3 days. Okay, so how I'm going to do 100 degrees centigrade for 20 minutes. For 3 days, I'm going to do this intermediate sterilization. For the next 3 days, I'm going to do. The main disadvantage of this mode of sterilization is sometimes you may not kill the spores. Vegetative spores cannot be killed. The next frequently asked area is hot air oven. The basic numbers are 160 degrees centigrade for about 2 minutes. Very frequently asked area is dusting powder, liquid paraffin wax, fat, grease, scalpels, swabs, forceps, scissors, glassware. All these, the mode of sterilization is going to be by hot air oven. Okay, right? Particularly very frequently asked areas are dusting powder, liquid paraffin wax, and all these are very frequently asked. Then comes the glass bead sterilizer. I hope you have seen this glass bead sterilizer in your endo departments. Here the numbers are very, very important. So glass bead sterilizer, the temperature is 425 to 475 degrees Fahrenheit. And it is in centigrade, it is 218 to 246 degrees centigrade. The holding time is regularly 5 seconds. And this holding time is very commonly used in the case of files and reamers. Files and reamers, 5 seconds. Okay. Paper points is a question which is already given in the examinations. Paper points, it is 10 seconds. The next comes is your burrs. Burrs is 15 seconds. Normal standardized holding time is 5 seconds only. Without mentioning the instrument name, if they're asking the holding time, your answer should be 5 seconds. Okay. 5 seconds for files and reamers, 10 seconds for your paper points, and 15 seconds for your burrs. Okay, right? Clear, guys? So that is called as glass bead sterilizer. Okay, which is used to sterilize smaller instruments, small instruments. Then comes the next one is, you can see in the anterior area on the buccal vestibule, you can see a blackish discoloration. This is basically called as amalgam tattoo. Probably amalgam tattoo. Probable reason could be they have used amalgam as a retrograde filling material. As a retrograde filling material. They have used amalgam as a retrograde filling material. Probably that could be the reason. Amalgam tattoo is basically amalgam in soft tissue. Okay. So that is one important area. Again, these are very frequently asked viva questions. Okay. So there is something called as amalgam blues. Amalgam blues are amalgam in hard tissue. And the third one is very frequently asked again, amalgam cry. Amalgam cry is basically sound that you get whenever you are carving amalgam. Carving amalgam, you get a sound that is called as amalgam cry. Carving cry. Hard tissue is blue in color. Soft tissue is amalgam tattoo. Okay. The reason why amalgam tattoo is going to happen is because of the retrograde filling material, and we are not using amalgam anymore. The main reasons is issues with biocompatibility. Not used corrosion products are coming. Dimensional changes are happening. Biocompatibility issues, discoloration issues, biosafety issues, allergy. The type of allergy that we see in amalgam is type 4, that is associated mainly with mercury uses, and everything are biologically not comfortable, so we stopped using amalgam. Amalgam in soft tissue is tattoo, amalgam in hard tissue is amalgam blue, amalgam carving sound is called as amalgam cry. Okay, right? So those are the most important things. I just need your response, guys. Hope the things are going fine from your side. I just need your response. Make sure you keep your bell notification on for all the notifications from MDS CONQUER on the YouTube channel. Okay, keep your bell notification on, subscribe the channel. Just need a quick thumbs up from all of you. 100 plus live students are there. Need a quick thumbs up from all of you, so that we'll try to extend half an hour more, and we'll try to learn few more important concepts inclined to the preparation. Okay, right. Okay, chalo, thank you. So next one is this is computerized expert system. There is something called as Comedix. This is a computerized expert system where this computer is going to take few information, facts about the case, info about the case, and the computer is going to do the diagnosis part. Okay, and this can be useful in not all the cases. It can be useful to differentiate normal pulp and abnormal pulp. Okay, and it can be useful to know the flare-up cases, infections, reversible pulpitis, irreversible pulpitis, endodontic flare-ups, infections, and all these can be diagnosed with the help of this computer expert system in diagnosis procedure. Okay, so I was talking about retrograde materials. Okay, in retrograde materials, I want you to, it's not exactly which is given in the textbook. So in retrograde materials, I want you to make a note about a rule called as rule of 3. It's not exactly the rule of 3. By remembering this rule of 3, you can remember, you can answer so many questions. Okay, what is this rule of 3 is talking about? So most of the things which are going to come in the endo, for example, retrograde filling material, I'm going to do in a periapical surgery. So whenever I'm going for a periapical surgery, I'm going to do a hole. Osteotomy I'm going to do. The size of the osteotomy that I'm going to do in modern endodontics, I'm not talking about traditional, I'm talking about modern microscopic periapical root surgery. The size of osteotomy I'm going to do is 3 to 4 millimeters. The size of osteotomy I'm going to do is 3 to 4 millimeters. Okay, next one. Next one, root and recession. Root and how much amount of root end I'm going to cut? 3 millimeters. How much amount of retrograde filling material I'm going to use? 3 millimeters. All these are 3 millimeters. Size 3 to 4 millimeters. Root end cutting 3 millimeters. And root end filling 3 millimeters. You can consider that as rule of 3, all threes. Okay. Why I'm cutting 3 millimeters? Anyone? Why I'm cutting 3 millimeters? Why I'm cutting 3 millimeters? Why I'm cutting 3 millimeters? The reason is most of the ramifications, lateral ramifications, apical ramifications, whenever I am taking my root canal system, okay, so I'm just dividing it into 3 parts, okay. So in the apical 3 millimeters part, okay, you have lots of ramifications are there, so many ramifications, lateral canals, apical canals, all this nonsense is there. So this is mainly responsible for infection holding. So that is the reason why, because this is a retreatment case, failed case. So what I'm doing is I'm cutting that part. Okay. So more than 90% of apical ramifications, lateral ramifications, and everything are present in the case of the 3 millimeters. That is the reason why I'm cutting those 3 millimeters. I hope this is very, very clear. So now I'm talking about retrograde filling material because you have a question on retrograde filling material classification in NEET 2022. So old generation, we have used metal alloys. And that too particularly we have used amalgam. Now we are not using amalgam. Other things are silver points has been used, gold foil is used, tin posts are used, lots of these things are used, but none of them are used nowadays. Now we are most commonly using is cements, out of which the most commonly used cement with highest success rate is going to be your MTA. I'm using MTA. Okay, I'm using MTA. Okay, right. Very important. Again, INICET question about MTA. They can ask you what is the initial setting time of MTA. The initial setting time of MTA is freshly prepared MTA is 10.4 and completely set MTA is 12.4. And this is called as highly alkaline. Anything above 9 is basically called as highly alkaline. Anything above 9 is basically called as highly alkaline. This highly alkaline was the exact term which is given in INICET. What is the pH criteria for MTA, set MTA or freshly prepared MTA? The answer is highly alkaline. Anything above 9 is basically called as highly alkaline. And resins are also being used, but the most commonly used are dental cements as of now. Okay, right? I want you to make a note about MTAD. MTAD is again a very, very frequently asked area. MTAD is basically an irrigation solution, which is a mix of tetracycline, acid, and a detergent. The tetracycline is nothing but 3% of doxycycline. Acid is nothing but citric acid, which is 4.25% of citric acid. And 0.5% of polysorbitate. And the detergent is 80%, the detergent is twin 80, which is detergent that is used in this particular scenario. Right? So it is doxycycline, citric acid, and a detergent. The combination of these three is called as MTAD. So MTAD is not a material, it is a irrigation solution. It is an irrigation solution. Okay, right? Clear? So similar to MTAD, you have something called as tetracline. Tetracline is also having a similar composition of MTA. Okay, MTAD, the composition is almost the same with slight difference in the numbers. These numbers are more important. Okay, these numbers are more important. Right, I hope you're clear with the MTAD. So now I'm jumping into few other irrigation solutions. So normally the most frequently used irrigation solution in endodontics is going to be your NaOCl. Percentages and everything we have already discussed. 5.2 to 2.5% is 6% is according to Engel, 1.5% is in the case of regenerative endodontics. The most important thing to be noted about NaOCl is going to remove the organic content, vital pulps and everything. It's going to remove the organic content. It has antibacterial effect on the pulp chamber. Okay, can you tell me any type of test which is used with the help of NaOCl helps in detecting the mist canals? Anyone? What test we do with NaOCl solution to detect the mist canals? What is the test basically called as? NEET 2023 question. Test which is used to detect the mist canals by using NaOCl solution is called as sham phase test. Okay, so bubbles are going to come whenever there is a mist canal and a vital pulp. Whenever you use NaOCl, okay, the bubbles are going to come. That is called as sham phase test. Okay. Other important thing is Riddle solution. Again, Riddle solution is again one more type of solution which is useful for mist canals, where you are going to have 17% of EDTA, 5% of NaOCl, and you have a radio opaque material called as hydrocon. So this radio opaque material is going to help you in diagnosing the mist canals. So after using this particular solution, I'm going to take a radiographs, and this radio opaque material helps in detecting the mist canals. The next one is RC prep. RC prep composition is important. So RC prep is a combination of EDTA plus urea peroxidase, whereas RC help is a combination of EDTA plus carbamide peroxidase. And Qmix is again a very frequently asked question. Qmix is a combination of EDTA plus chlorhexidine plus triclosan. And of course, other important areas where questions are very frequently coming is E. faecalis. E. faecalis is one of the most important microorganism for endodontic failure or endodontic infections. Okay. Questions which are already given is most common organism detected or organism primarily responsible for occurrence in the failed root canal systems is E. faecalis. So these are the notes straight away from your Grossman, which are very, very important. E. faecalis is a gram-positive facultative anaerobic cocci that is strongly associated with endodontic infections. And it's a persistent organism despite making the smaller proportion of flora in untreated cases, but plays a very, very important role in persistent periapical infections of the root canal. So this is the most common organism responsible for failed cases. Commonly found in highest percentage in the root canal failures because of its ability to survive in the root canal system as a single organism or as a major component of the flora. The survival capacities. Okay, so this is what extremely alkaline because whatever materials we are going to use, calcium hydroxide and all these materials as a disinfectants are extremely alkaline material, because the disinfectant what we are going to use in the weeping canals and all this is your calcium hydroxide. Sorry, calcium hydroxide, which has a pH of 11 to 12, which is extremely alkaline. So this E. faecalis can grow in extremely alkaline environment, in salt concentration environment, and a temperature range of 10 to 45 degrees centigrade, and even at 60 degrees centigrade for 30 minutes it can survive. So that is the reason making its removal very, very tough in endodontics. 40% occurs in primary endodontic infection and 24 to 77% occurs in persistent endodontic infection, causing the organism primarily responsible for failed RCs. Reasons it possesses, apart from its ability to survive in pH, variable pHs, it has virulency factors that are able to cause periapical disease, stem cells, and its ability to survive in the effect of the root canal system. Persistent pathogen in the case of your root canals and even in the case of your dentinal tubules. Again, this is a diagram based question already given in SR ships of INICET in endo. So please do make a note. Very, very important diagram of E fecalis. Okay, so in Grossman, the other important lines which are given, most of are self-explanatory. Okay, so as already discussed, it's going to bind to the dentin and invades the dentinal tubules, alters the host response, and suppresses the action of lymphocytes, immune system, and it releases some lytic enzymes, utilizes the serum as a nutrition source, resists high alkaline intracanal medicaments like calcium hydroxide. It competes with other cells, form strong biofilms because of its virulency factors. A very, very important line which is given in INICET is E. fecalis biofilms are 1,000 times more resistant to phagocytosis, antibiotics, and intracanal medicaments like calcium hydroxide. Now we got a consist of 1,000. Okay, any other thousands you can add on? What is the drug of choice for anaphylactic shock or atopy or type 1 hypersensitivity? The answer is 1 is to 1000. 1 is to 1000. Sorry. The answer is 1 is to 1000. Intramuscular best option followed by subcutaneous adrenaline. That is 1000. You have to make a note. Integrated to other subjects. One more 1000 integrated to C factor. C factor value of root canal filling material is C factor value of root canal filling material is around 1000. So both these thousands, so please do make a note of both of these thousands. C factor value for a root canal filling material is around 1000 or more than 1000, and drug of choice for anaphylactic shock is 1 is to 1000 intramusculars followed by subcutaneous adrenaline. Okay, so other important areas are MTA and gutta-percha are very, very important. The composition of gutta-percha is given by Friedman. It contains 20% of gutta-percha, 65% of zinc oxide, which acts as a filler, 10% of metal sulfate acts as a radio-opacifiers, and 5% of waxes and resins, which are going to maintain the plastic property. And gutta-percha, whatever the form of gutta-percha that is available for us is beta form. So gutta-percha is available as beta, alpha, and gamma. 3 forms are available, where alpha form is not used. Okay, so whatever form that is visible to your naked eye in the departments is beta form. You heat beta form is going to convert into alpha form. You heat alpha form or you overheat beta form, that's going to convert into gamma form is completely unstable and it is not used. So it is basically only 2 forms of gutta-percha which are useful for us. One is beta form is used in lateral condensation. Whatever that is visible to the naked eye is used in lateral condensation technique. You heat them, plastic properties are going to develop. So this is used in thermoplasticizer gutta-percha technique. Plastic properties, right? Plastic properties is alpha gutta-percha. Guys, I hope this is very, very clear. Very, very important concept. Gutta-percha, whatever that is seen, the pink color gutta-percha, whatever that is seen, the pink color gutta-percha, whatever that is seen is beta form. I'm going to use beta form as very, very tough. So beta form I'm going to use in lateral condensation. So I'm going to insert cone by cone. I'm going to do lateral condensation. I'm going to one more insert cone. I'm going to do lateral condensation. One more cone. I'm going to do lateral condensation. So beta forms are basically used in lateral condensation technique. I heat the beta form. Beta form is going to convert into alpha form. Plastic properties are increased. Where it is used, converting, I'm using temperature. I'm using heat. So that is the reason why it is therma. I'm increasing the plastic property. Thermoplasticizer gutta-percha technique, which form? Alpha form. I heat beta form, alpha form at a higher temperature. It burn off, completely crashed and burn off. That is called as gamma form, which is nowhere related to endo. Guys, I need your quick response. Yeah. Right. So this is what gutta-percha we are basically talking about. So now I'm looking into MTA. The scientist name is Thora Benachad, and it is basically obtained from Loma Linda University of California. Okay, so during your gold cavity preparation. During your cavity preparations, you have something called as Loma Linda University class 5 cavity preparation also. So look into the diagram based question, which is again given in INICET. So Loma Linda class 5 cavity preparation design is very, very important. So MTA is primarily composed of tricalcium silicate, dicalcium silicate, tetracalcium aluminate, and tetracalcium aluminoferrate, which is present in gray MTA, and this is absent in white MTA because that is the primary agent which is responsible for occurrence of discoloration. Apart from this, I am going to add an oxide, bismuth oxide, which is going to provide me a radio opacifier. So which component of MTA is absent in the white MTA, present in the gray MTA? Your answer should be tetracalcium aluminoferrate. The other important point I just want to add to your preparation phase is discoloration. Discoloration is mainly associated with tetracalcium aluminoferrate. In few areas, it is also mentioned that your bismuth oxide is going to cause discoloration. Okay, so what I have done, I have replaced tetracalcium aluminoferrate. I have removed it to convert into white MTA, and bismuth oxide can be replaced by titanium oxide. Again, this is an INICET question. How? Even bismuth oxide is also causing discoloration. So I have replaced bismuth oxide by titanium oxide in the case of neo MTA. So white MTA, I have removed this TAF, whereas neo MTA, I have removed bismuth oxide. I hope this is very, very clear. Both of them are responsible, but best answer is TAF. Neo MTA, I have replaced BO with TO, whereas white MTA, I have removed entire TAF because I have removed BO because BO is basically a radio opacifier which is required for me. So I cannot remove that straightforward. So I have to find out an alternative where I have used titanium oxide. Your MTA also contains some traces amount of free crystalline silica. That is very, very important. And a traces amount of calcium oxide, free magnesium oxide, potassium, and sodium sulfide components also. Okay, right? And we have already discussed about the freshly prepared pH of MTA, that is 10.4, which is highly alkaline. And total set, it is 12.4. Initial setting pH is 10.4, final setting pH is 12.4. Both are highly alkaline. The setting time is 165 minutes. It has a long setting time. That's one of the biggest disadvantages of MTA. Biggest disadvantage of MTA. One is high setting time. Second one is handling properties. MTA is very poor in handling properties. It does not stick to the things properly. It is like a sand. Okay, so two important disadvantages of MTA is high setting time and handling properties are very, very bad. How I'm going to sterilize the gutta-percha? I'm going to sterilize the gutta-percha by 2.5% of NaOCl for about 1 minute. Okay, so now I told you, right, when I was talking about calcium hydroxide, the biggest difference between calcium hydroxide and MTA is there is no coagulative necrosis associated with MTA, whereas coagulative necrosis can be seen associated with calcium hydroxide as a response whenever it is placed on the pulp. So calcium hydroxide powder, which is going to contain tricalcium silicate, dicalcium silicate, tetracalcium aluminate. Okay, and in the presence of water or blood, that is one of the biggest advantages again. Even in the presence of blood in the periapical areas and everything, MTA can set. MTA always requires water for its setting. So that is process is called as hydration. Again, MTA, what I'm going to do, I'm going to fill with MTA in epexification and everything. I'm going to keep cotton pellets filled with droplets of water. And I'm going to ask the patient to come after the next day to remove those cotton pellets because it requires hydration for its setting. So hydration reaction is very, very important in MTA. So with calcium silica, it is going to form calcium silico hydrogel after 3 to 4 hours. That is around like 165 minutes plus. This porous gel, initially, it solidifies into a hard crystalline structure, which is becoming so tough. And normal CaOH that is present, it increases the pH because we have already know the calcium hydroxide. Normal calcium hydroxide pH is only 11 to 12. The same calcium hydroxide present in MTA is going to increase the initial pH 10.4 to final pH of 12.4 or 12.5. The other important INICET repeat that you have to make a notice, the setting expansion of the gray MTA in the presence of water is 1.02 percentage. So on future, you can see gray MTA. This is gray in color. So this gray MTA is basically associated with discoloration. It's going to contain aluminoferrate in it. So aluminoferrate is basically removed from this gray MTA, converting this gray MTA into white MTA. So this is gray MTA, white MTA diagram based. Now difference again, gray MTA, white MTA difference. We have already discussed the major differences. Tetracalcium aluminoferrate. So tetracalcium aluminoferrate or ferrous oxide, which is responsible for grayish discoloration of the teeth. So not used in anterior teeth, it can be used in the posterior teeth. So now what I have done, I have replaced this, I have removed or I have replaced this ferrous oxide by magnesium oxide to prevent this discoloration to occur. Gray MTA are particle size is larger, whereas white MTA the particle size is smaller. Gray MTA have longer setting times. This has shorter setting time. Gray MTA has more compressive strength, that's the biggest advantage, whereas your regular MTA has less compressive strength. So these are the most important points to be noted. Okay, right. So now I'm coming to the last part. So as promised, I'll be closing the session in the next 10 minutes. Okay, I just need a thumbs up sign from all of you guys. Quick thumbs up sign from all of you. 80 plus students are there. I need a thumbs up sign. One. Second thing, make sure I want you to subscribe the channel. Keep your bell notification on for all the updates, notifications and everything. Make sure like the video, share this video with your batchmates or juniors who really require this particular session. Okay, I just need your thumbs up sign, all of you, please. I'll be talking about monoblock technique, which is above the standard of a UG student, but you have questions on this monoblock technique, both in the NEET, very common area in INICET. A few concepts are already discussed when I'm talking about post and core and FPD integrated part. Okay, but we'll try to do it again and again. I just need a thumbs up sign from all of you. 10 minutes, we'll learn monoblock, very important concept. Very important concept. So whenever I'm doing root canal therapy, so most of you have done root canal therapy. So this is the cross section of a root canal therapy. A is a cross section of a root canal therapy. We'll be having isthmuses, we'll be having ramifications, we'll be having some minor errors that you do, improper errors. All these are going to form one system. So this entire system, you can see this entire system. So this is the entire system, white color entire system is root canal system. But whenever I am doing my obturation, my focus is just keeping the cones. That is what I do. So this is one cone I kept, this is two cone I kept. I'm least bothered about the leftover space. Then followed by in lateral condensation or in any other sorts of preparations. Okay, what I'm going to do, I'm going to add few more cones. Okay, sometimes, and I'm going to add some sealers, and I'm going to, whatever it is, your entire spaces are not filled properly. But what type of unity I expect in my root canal system is this one. Means whatever you keep inside, whether you keep multiple cones inside, whether you use thermoplastic or gutta-percha technique, whether you use fiber posts, whether you use sealers, whether you use whatever it is, everything should form together as a single block. So whenever the single block is being formed, then the success rate of this root canal therapy will be more. So that concept is called as monoblock technique. Whatever you keep, all the blocks fuses together, bonds together to form a single block, that is called as monoblock. And whenever you have this monoblock, okay, the success rate will be more. That is what the monoblock is basically talking about. Okay, very important concept, a little tricky concept, but I'll try to make it as simple as possible. So you have a group of friends. So for example, one orange friend is there, one green friend is there, one blue friend is there, sealer friend is there. I kept a fiber post. That is one more friend, yellow color friend. If I am keeping a metal post, black color friend is there. All these friends together to form a one unit in the root canal system. If the bonding between these friends is good, if the bonding between all these multiple friends is good, then they together form a one block that is called as monoblock. If the bonding is bad between you, if the bonding is bad between your team, okay, then monoblock cannot be formed. The team cannot win. So if it is a single block, the team is going to win. What are the factors which are plays a very, very important role in this blocking or in this unity is very, very important, which we'll be discussing. So now the dentistry is becoming very, very good advanced because of the technology that is called as adhesive technology. All these bonding agents, dentin bonding agents, and all these are very beautiful. They increase the unity among the friends, different friends. So adhesion, bonding is important. Monoblock to be successful, root canal to be successful, monoblock obturation to be successful, the most important thing is bonding, that is adhesion. Adhesion is important. What monoblock? Definition is monoblock obturation system is a unit in which the core material, sealing agents, and the root canal dentin all together form a bond. That form one bond, one single block is called a single cohesive unit. That is basically talking about your monoblock. Now, basing upon the interfaces, how many interfaces are there, how many friends are there, your blocks are being divided into primary block, secondary monoblock, tertiary monoblock. How they are divided? Basing upon the number of interfaces present between the bonding substrate and the core. Number of friends, more interfaces, that is called as tertiary. Only one interface is there, that is called as primary. So now first one is very, very important, is one is diagram based question already given in INICET. Okay, exact diagrams I'll be showing. Second one is examples. Concept I hope you can handle. Primary monoblock, you can see in primary monoblock you have only one interface. Primary monoblock has only one interface that extends circumferentially between the material and the root canal wall. So you have only one interface, because here you have two friends and you have only one interface. Examples are important. The memory based aspect is examples. Hydron, MTA, biogutta, okay, your polyethyl fiber post core buildup, and all these are going to be the examples of your primary monoblock. Secondary monoblock are going to have two interfaces. Here you have three friends, one white color, two yellow color, three. So interfaces, how many you have? One interface, two interface. Secondary monoblock is basically you are going to have two interfaces, one between the sealer and the dentin, and the second between the sealer and the core material. Examples again are important. Resilion, ProPoint, C-cones, prefabricated post and core system. All these are going to come under the examples. Question which is given in the NEET couple of years, 5-6 years back, is about the concept of tertiary monoblock. Tertiary monoblock, I'm going to have three interfaces. One between sealer and dentin, second between the sealer coating that has been applied over the non-bonding gutta-percha points, and the third one is coating and the core material. So I have three interfaces here. I have four different color materials here. I can see 1, 2, 3, 4 different colors. I have three interfaces. It's called as tertiary monoblock. Examples are important. 1 year I have already discussed about active GP. So 1 year active GP example was given, and the second year ENDODONTICS example were given. So both this ENDODONTICS and active GP are going to come under tertiary monoblock technique. Okay, I told active GP is a combination of gutta-percha with glass ionomer cement. So this is an exact diagram which is given. Primary, secondary, tertiary. These are the exact diagrams which are given in the examination. Tertiary monoblock. This diagram based question straight away from your standard textbooks was given in INICET. Okay, now for this to happen, there are some requirements. Okay, so two very important requirements for a monoblock to function as a mechanically homogeneous unit. One is bonding, perfect bonding, perfect adhesion. I require perfect adhesion, should be able to bond strongly and should be able to form strongly, should be able to carry it mutually. So I want a strong bonding. One important thing is strong bonding between us. Second one is sealing ability. So whenever there is a failed of sealing ability, flowable, sealing ability and everything we have discussed, like contact angle and everything in DM we have discussed. So whenever you have a poor adhesion, whenever you have poor wetting properties, whenever you have polymerization shrinkage, or whenever you have thermal stresses, occlusal load, water absorption, all these are going to damage your sealability. Okay, sealability, and that lead to failure of this obturation material. Okay, right. The next one is the teeth with significant coronal tooth structure lost requires post. That's already we have discussed. And interest of retaining the core. I'm going to give the post. Why I'm going to give a post in post and core? That is useful for retention. Very, very frequently asked question. And since the currently favored the fiber posts are partially retained in the root canal system, and you require an adhesive cement. Okay, so sealing ability is again associated with post and core with a proper adhesion. The next comes is the second important thing is the modulus of elasticity. Whatever fiber post I'm going to use, this again we have discussed integrated concept. I'm talking about this particular modulus of elasticity, coefficient of thermal expansion, all the values of your fiber post are similar to that of the dentin, then only your restoration can withstand. If it is not similar, what fractures can happen? What fractures can happen? You can clearly see vertical root fractures. Vertical root fractures are happening. So you give a metal post, what is going to happen? Metal post will have more coefficient of thermal expansion. So metal port expands more if you don't give the dead space, and vertical root fractures are very, very commonly seen in the associated with metal posts without a dead space. So all these things we have discussed. Last but not the least part of today's class is generations of these bonding agents which are used in endo. The first generation examples are important. First generation examples are important. Already given in the NEET 2018. Okay, first generation was given. Okay, Hydron comes under which generation of bonding agents in root canal system? It comes under first generation. Endoris comes under second generation. Okay, then the third generation is Epiphany Resilion going to come under third generation, and fourth generation is going to be Metasil. So don't get confused with the generations of bonding agents in your operative dentistry. They're going to clearly mention, okay, generations of bonding agent used in endo are slightly different between the generations of bonding. Conceptually they are same, okay, but example wise it is different. Endoris and Epiphany were the questions which are already given in the examinations, already given. So nice notes was given for all this entire class, already posted onto your groups, and I hope you guys are working on that notes. So with which I'm done with today's session. I hope there are very important concepts which we have discussed in today's session. Okay, and I hope all the concepts are clear. If you have any doubts, you can post me on my WhatsApp number so that I'll try my best to help you out, guys. Other important updates from my side is make sure subscribe the channel and keep your bell notification on, and like this video and share to your batchmates who really requires boot camp at this particular phase of prep. And note is dates were not out, and we are left over with 10 days to hit this 2025 year and jump into 2026. Predicting exam can be little late, so guys, I want you to be little serious. Increase the seriousness. So your chances at a state level, or your chances at an all India level, or your chances in your category level, or in your chances in your journal level will be more. So don't compare with your batchmates who are not serious about prep. So at least now, if you react, plan things properly, boot camp is definitely going to help you, and it's going to be a game changer in NEET 2026 for your preparation to enter into MDS in less than 6 to 8 months from now. So all the best. Take care. See you. I'll be back very, very soon with one more important update. And the upcoming December 22nd evening, that is Monday evening, we are planning to have one more live session exclusively for the people who want to restart their preparation for 2027 NEET, who want to restart their preparation for INICET, or who have started their internships recently, or who are planning to move to USA for DDS programs, INBDE, ADC, or you're planning to go with Dubai license exam or any sort of DHA examinations, whatever it is, PSs and everything. We'll sit and talk some good things about the good aspects and future of dentistry. So you can join that particular class and share this information to your juniors, sub juniors, final years, all well wishers in the dental fraternity. Bye, take care. See you guys.